My pleasure to introduce Dr. Joshua Levy, who's the Director of Digital Pathology Research at Sinai and an Assistant Professor in the Departments of Pathology and Computational Biomedicine. Dr. Levy's research focuses on integrating visual intelligence and biostatistics in anatomic pathology, developing computational methods for histopathology, cytopathology, text and image processing, and analyzing spatial molecular variations in tumors through spatial genomic technologies, amongst numerous other application areas. His academic path commenced with a physics degree from the University of California, Berkeley, followed by computational biology and software development roles at Lawrence Berkeley National Laboratories, and in industry leading to a doctorate in quantitative biomedical sciences from Dartmouth College Basel School of Medicine. At Cedars-Sinai, his goal is to establish a nationally recognized digital pathology research program and create student recruitment pathways to bring new talent into the field. Dr. Levy is going to talk to us today about digital pathology and artificial intelligence for spatial interference and multimodal integration.
Hi, everyone. Oh, does this mic work? Good. Good. Hi, everyone. So I'd like to start today's presentation by thanking Alex and the Spatial Biology Conference organizers for the opportunity for me to present my team's work. My name is Joshua Levy. I'm faculty in the departments of Pathology and Computational Biomedicine at Cedars. As was mentioned, I'm the Director of Digital Pathology Research. And while you all probably know, I'm not a pathologist by training, I do work on tools that I think may provide value to folks in the department. Before Cedars, I was an assistant professor at Dartmouth for several years with appointments in pathology, dermatology, and epidemiology, and I now hold adjunct appointments there, and I provide machine learning consultation at the Veteran Affairs and the Biomedical National Elemental Imaging Resource. So today, what I'm going to do is I'm going to provide a broad overview of my team's interests in spatial analysis. And this will largely focus on applications of AI and machine learning for inference of spatial transcriptomics information from histopathology. So I prepared an extensive set of slides covering a wide range of topics with a focus on breadth over depth. And I'm going to touch upon many of these points quickly. So rest assured, there are summary points for each of these slides, and I'm also available for follow-up afterwards. So first, I'll provide a brief overview of histopathology and AI for folks that are unfamiliar. Then I'll describe a few select projects that of many that my team are working on, specifically for enhancing spatial analysis, including how AI can predict intricate molecular spatial patterns without the need for advanced assays like Visium. And then I'll discuss some of our up-and-coming work combining various types of spatial assays, followed by some closing remarks. So a little bit of background on who I am. As was mentioned, prior to my dissertation work at Dartmouth, I majored in physics at Berkeley for my undergraduate. I realized early on I didn't want to wind solenoid coils for 40 hours a week. So I pivoted into software. And I spent a few years developing bioinformatics software at Lawrence Berkeley National Labs and as a software engineer in industry. And this led to my doctoral work, which centered around developing deep learning technologies that could parse information from high-dimensional omics and imaging data. And since completing the PhD, I've been thinking a lot about how these technologies could be optimally interfaced with clinicians. So over the past few years, I've run a lab at both Dartmouth and Cedars. So here I've included a few pictures of folks in my lab. This is a highly interdisciplinary, collaborative research group. I've been really lucky to work with them over the past few years. So many of the findings that I'll present today are the byproduct of their hard work and creativity. So what's my team focused on? Well, our design philosophy is to enhance medical practices in a user-driven way, keeping the practicing pathologist in mind. For instance, pathologists in the lower left can quickly spot tumors on a slide, but in the lower right, counting tens of thousands of cells in a cytology slide is a far more challenging and tedious task, and thus one worth prioritizing. And secondly, for the purpose of this symposium, we're keenly interested in further developing and applying methods for characterizing spatial molecular heterogeneity, both within and around tumors. And now this goes without saying for this group in particular, but these technologies provide cell and position specific gene and protein expression measurements, allowing us to localize specific lineages within distinct architectures. So now I'm going to set the stage for our spatial work, and I'll do this by more formally introducing digital pathology. I'm going to reference a few relevant imaging and computational methods of many with a focus on machine learning. So digital pathology signifies the transition from a conventional analog technique of examining tissue into a more streamlined digital format. And developing this infrastructure offers a wealth of benefits across clinical research, operational, and educational domains. And while I develop technologies to enhance clinical decision support and improve operational and educational practices, most of my talk today is going to be spent on how we can leverage digital pathology to facilitate development of novel biomarkers with potential for real-world clinical use. For example, our group mostly works with whole slide images. These are digitized representations of tissue slides that can expand up to 300,000 pixels in any given spatial dimension. And so we develop machine learning algorithms that operate on these images to quantify biomarkers and histopathological features relevant for diagnosis and prognosis, like tumor-infiltrating lymphocytes. And with the burgeoning use of genomics and imaging technologies, this has led to an explosion of data that can be analyzed. So each patient's profile can now includes a wide array of different factors, from clinical characteristics to genetics and complex imaging, and all this data together can make it really challenging to discern all the key patterns linking this data to various patient outcomes. So this is the purpose of machine learning. This is a data-driven approach that can find key, sometimes non-obvious patterns within a large set of clinical factors that approximate the relationship between your input data and your target of interest. So this target can be something that's known. We refer to that as supervised learning. For instance, in the lower left, utilizing the patient's mutations to determine whether they have melanoma. Alternatively, the target can be something we don't know, and we refer to that as unsupervised learning, focusing on similarities and differences between the mutations to group patients together, and some of these groups may respond well to therapy. I'm now going to provide an example of a supervised learning algorithm. So this is my cat, Jarvis, on the left. He's a very handsome, playful, and mischievous cat. And I want to detect Jarvis if Jarvis is a cat. And we know by looking at this image that he's obviously a cat, but the computer doesn't know this. So I'm going to report a few descriptive features of the cat. For instance, the number of ears, the color of the eyes, the length of the whiskers, etc. And then I'll record whether this image is a cat. And I'll do this for thousands of other images. And so these labels serve as the gold standard because in general, we're all really good at distinguishing cats versus dogs. And this is a supervised analysis because it's being done with the help from humans in the form of labels. The algorithms I often use are called artificial neural networks, which are part of the deep learning methodologies. These are inspired by processes of the central nervous system, where the basic unit of analysis is a node. And signals pass between large collections of nodes to process this signal into action. So given the appropriate activation, this signal may be passed or shared. And as you can see at the bottom, these neural networks are organized into multiple processing layers that represent objects at varying levels of abstraction. So these artificial neural networks are particularly adept at identifying relevant, high-quality features based on raw, unstructured imaging data. And one way I like to think of these neural networks is as algorithms that learn to match shapes. So they will algorithmically decide for themselves what shapes and patterns in the image inform the image of the cat. So if we start with this shape of the ear in the center of the slide, I'm going to record where on this image that ear shape occurs by sliding this shape over the image and registering that on the map on the right. So you can see I've done this here. I've recorded that match with the green square. I can do this for the eyes, the paws, and now we can see we have an algorithm that's located ears, eyes, and paws, and we can use this information to predict whether Jarvis is a cat. And what's really cool about these neural networks is that before these algorithms learn from the data, they have no idea what ear, eyes, and paw shapes are, but by the process of continually making the mistake of rating a cat as a dog, over time, they're going to learn shapes that are indicative of cats. So now we're going to apply these concepts to histopathology. So these deep learning models can learn to find important shapes and patterns in the image that inform the prediction without requiring human specification. If I ask the model to tell me what it's seeing, for instance, it's picking up patterns of leukocytes in the liver in the lower left, or aspects of abnormal cellular morphology in the upper right, or recapitulating patterns of lung adenocarcinoma. So where we use these technologies, well, right now I'm just going to share a few brief examples of where we have applied deep learning analysis to enhance medical decision making. For instance, in this slide, my team developed an interactive web-based diagnostic decision aid for cytopathology. So this particular application will make bladder cancer screening and surveillance more expedient and reliable by rapidly analyzing hundreds of thousands of cells at a time and focusing the pathologist's attention on the cells with the highest malignant potential. Here's another example of an AI system. And so this is a tool that we developed to enhance intraoperative tumor margin assessment that can significantly improve the precision and efficiency of tumor removal. So what this technology does is that it can identify positive tumor margins from dozens of serial sections in real time and stitch together a 3D model of the tumor to inform where further excision is needed while the patient is under general anesthesia. So if there's anything to take away from these sections, it's that histopathology involves the examination of tissue for abnormal histomorphology suggestive of malignancy, and that machine learning models can help us study this information. And of these techniques, deep learning techniques offer flexibility in how this information is captured. So moving onwards, I'm going to discuss numerous areas where we are applying these AI methods to enhance what can be learned from emergent spatial assays for facilitating biomarker development. So it goes without saying that there's a plethora of cutting-edge imaging and sequencing tools to accurately map protein and gene expression within distinct spatial configurations. And this, as you know, presents an advantage as compared to conventional bulk analysis, which may otherwise mask these prognostic markers that could be unique to specific tissue architectures. So my team has primarily focused on incorporating the Visium spatial transcriptomics assay into our research. This assay allows us to analyze between 5,000 to 14,000 spots on a single tissue slide, with each spot capturing the expression of around 18,000 genes at a time between 1 to 10 cells. And so this method offers high resolution, untargeted profiling. And of relevance to the upcoming slides, the same tissue section that we're profiling with Visium has also been stained with H&E or immunostained and imaged at 40x resolution prior to the profiling. So this assay can enhance our study of spatial biology, offering numerous applications that I've highlighted here on the current slide. So while many of you are familiar with these kinds of analyses, I'm just going to provide a brief review of these various applied methods just to demonstrate where our work fits in this context. For example, you can cluster spots by their expression profiles, and this essentially mirrors the way we can group single cell data together to identify cell types with a common lineage. And so here we're highlighting similarities in expression patterns that are tied to tissue architecture. There are various emerging assay technologies that allow us to map the single cell data to their precise locations on a tissue slide. We can localize novel cell lineages and enhance the detail of the Visium data. Similar methods allow us to discern proportions of cell types at each Visium spot. And there are several bioinformatics methods that can capture spatial relationships between cell types. As many folks had mentioned earlier today, studying various intercellular communication patterns. And finally, there are several approaches that allow us to synergize histology with spatial transcriptomics to enhance the resolution of the data. So my lab's primary research focus is to infer this information directly from the histology where this spatial transcriptomics data is not available. And so this can potentially allow for population scale inference at minimal cost, which can facilitate biomarker development. So by inferring the gene expression, we can apply the same techniques that I had just mentioned in the previous slides as if that data were just assayed within reason. To this end, our current research interests were motivated by some of our work several years ago in a technology called virtual staining. This is a cost-effective digital alternative to chemical staining. So this allows us to discern diagnostic and prognostic molecular features from a single digital stain without the traditional reagents, where the morphology allows this inference. So this technology could potentially help bypass the costs and labor of these chemical processes needed to produce immunohistochemical stains to target these biomarkers. And just to give an example of where we've applied this, this has led to several impactful large-scale validation studies from our group, such as one to assist in the analysis of liver biopsies for non-alcoholic steatohepatitis. So these initial works gave us confidence in applying similar methods to spatial transcriptomics data. So since then, we've actually collected close to 100 colon, skin, breast, and placenta samples, all of them assayed for Visium spatial transcriptomics. All of these slides co-registered with same section H&E whole slide images scanned at 40x resolution. And so similar to the virtual staining methods, we developed spatial inference technologies for this data that can infer spatial gene expression patterns from tissue histology for thousands of gene expression markers at a time where this spatial omics data is not available. So in order to do this, we compared the performance of several different algorithmic methods for spatial RNA inference, for instance, from graph neural networks that I visualized here, to transformer architecture similar to what powers ChatGPT. And so these methods can allow us to study the surrounding tissue context in making these predictions. Now I'm going to share a few use cases for these methods. So initially, we sought to apply this approach to study colorectal cancer. I know several groups earlier today had I mentioned various use cases here. And so this, as many of you know, this is one of the leading causes of cancer, with 150,000 new cases a year and over 50,000 deaths annually in the United States. Metastases account for approximately 90% of fatalities. So developing efficient, rapid, cost-effective screening and prognostication tools are critical for disease management. So we wanted to identify a spatial signature at the primary site that could complement existing staging practices, especially for scenarios where assessment of lymph node yield during resection is inadequate. So while there exists several assays that capture signatures of pluripotency as an example, I know someone mentioned CDX2 earlier today, cytotoxicity of tumors, CD3, CD8, and various circulating tumor markers. We believe this virtual inference can allow us to expand the scope and range of spatial RNA markers that could be assessed in large cohorts, helping us identify novel recurrence risk factors and permitting their comparison against the prevailing methods. And then in a separate feasibility study, we aim to assess photocarcinogenesis and molecular signatures of accelerated aging in skin by leveraging tissue imaging to study sun damage. So while many of these studies that exist study dermal fibroblast changes and collagen depletion, this approach allowed us to explore deeper dermal changes beyond the UV penetration depth in a more cost-effective way for large cohorts, though this work is very much in progress. So what did we find for both of these pilot cohorts when we applied our methods? Well, together, these methods were able to predict the expression of 1,000 genes with moderate to high accuracy. So here's a digital display output at the bottom left of the screen that shows what the predicted expression looks like for a few select genes. So I've highlighted an example here denoted by the red star. And if we visually compare this data, we could see that areas of high expression are relatively aligned between the ground truth and the predicted data, though it's important to note that this alignment is not perfect. We also noticed that genes that could be predicted with high accuracy also carried some biological relevance. So interestingly, for our colon analysis, these neural networks were capable of detecting pathways relating to the epithelial to mesenchymal transition, hinting at their potential for metastasis-related research. And in skin, we found that the top-performing genes were crucial for tissue-specific activities like epidermis formation and keratinocyte proliferation, in contrast to lower-performing, more universally expressed genes. On this slide, I'm going to share how these algorithms can be incorporated into a digital pathology workflow. So on the left, what we've done is we've scanned entire colon tissue slides as whole slide images. And then our virtual molecular inference algorithm can estimate the gene expression for thousands of genes at near cellular resolution. And on this slide, I've included the real output displays from our algorithm on the right. This is unpublished. We're writing the manuscript as we speak. And I just want to note here the upregulation of cyclin-dependent kinases in the tumor and the epithelial regions of the colon slide, and activations of collagen markers like Col6-1A and 6A1 in the normal fibrous stroma, mucosa, and the mesenchyme. And I really just want to emphasize here that we perform no molecular profiling to produce these expression patterns. Just the images suffice. And I think this is also a good time to mention briefly that these methods can be configured to infer expression patterns at higher resolution than the original models that were trained. And this is because we're inferring expression patterns based on the imaging features. And these imaging features can be extracted at any point in these tissue slides. As a further analysis, we wanted to see whether the inferred expression patterns made sense. That is, we would expect these markers to be aligned with various tissue histology. So everything you're seeing on the right side of this slide are inferred expression patterns for a few select genes. And so what we did here was we performed a differential expression analysis comparing the inferred expression patterns at various tissue regions, such as the normal epithelium to the tumor, and comparing those to the muscularis propria, amongst other examples. And from these differential expression results, we ran a pathway analysis, which revealed pathways associated with the architectures that you would expect, which I've included as headings on the right side of this slide. So I've listed a few pathways over there. For instance, we observed that expression of genes associated with smooth muscle pathways predominantly occurred in regions corresponding to the muscularis. Switching back to our skin study, here's an example of inference on the skin tissue slides that have not been profiled yet for spatial transcriptomics. This revealed activation of other relevant biological pathways, for instance, localizing keratinocyte differentiation by localizing KRT15 in skin. And since our initial pilot studies, we've been developing innovative methods for studying the data at cellular resolution. So we're working on inference from single cell expression from histology. This has been accomplished using a co-mapping approach. So on this slide, I've left an animation that shows how spatial transcriptomics can facilitate the mapping between paired single cell RNA-seq and extracted single cell histological features. For the sake of time, I don't have time to cover this application, so this is just a preview, but I'd love to meet with folks after the presentation to discuss. So what are the key findings from these feasibility studies? Well, they demonstrated feasibility of these approaches. We also found that genes that were predicted with higher accuracy tended to be associated with the formation of diverse tissue architectures, which served as validation for our approach and gave us confidence that we could potentially apply these approaches to larger cohorts when studying the pathogenesis of various conditions. So now that I've introduced some of our initial work for inferring these patterns from histology, I'd now like to discuss how we're improving our spatial inference methods as we prepare for large-scale validation work. So while I think you could tell from this presentation that I primarily develop and apply machine learning methods, I think you'd be surprised to hear from me that I'm actually not convinced that developing and improving the state-of-the-art machine learning approaches will lead to the greatest performance gains for these spatial inference methods. Instead, I think we stand to gain the most from how we prepare specimens for profiling. So I recently surveyed the prior art for spatial inference technologies, and I found that across the board, the tissue used in these analyses were typically frozen sections. They were manually stained and imaged with lower resolution scanners. And as such, it would make it very challenging to apply these algorithms that were trained on that data within most clinical grade digital pathology workflows, which typically rely on permanent sections, consistent staining, and high resolution scanning. So it begs the question, is the data that we're using for developing these spatial inference algorithms of sufficient quality? And so this question motivated our follow-up work, which explored the impact of how staining and imaging could potentially impact the viability of these spatial inference workflows. So we hypothesized that improving the specimen processing would improve the performance of our machine learning models. And so to test this, we compared a traditional protocol, which relied on manual staining of tissue and scanning at lower resolution, with an enhanced protocol that automated tissue scanning, and we also scanned at 40x resolution using clinical grade scanners. Machine learning algorithms were trained on data resulting from both of these protocols and separately validated on two serial sections that were positioned within the same tissue architecture but separated by 5 microns. One section was processed using the traditional protocol, the other with the enhanced. And then how could we determine the usefulness of this enhanced protocol? Well, we wanted to quantify the impact of the protocol by comparing the algorithmic performance improvements attributed to individual slides that were processed using these protocols versus their fiscal costs in the specimen assaying. So this was accomplished using the data Shapley value. And what is the data Shapley value? Well, it's a measure that quantifies how much the performance of a model increased given the introduction of an individual tissue slide, accounting for all possible permutations of the training data. So prior applications of these approaches in various fields confirmed something that we consider to be common knowledge, that data quality, should, as we'd imagine, impact algorithmic performance. However, this method can help identify data points or individual slides with the greatest impact. So what we did was we calculated data Shapleys for individual tissue slides. We compared the values for each of the slides data for enhancing the performance with the costs of specimen assaying. What did we find? Well, our results were clear and they exceeded our expectations. And as far as algorithmic accuracy, we noticed that the enhanced protocol led to an 150% improvement in predicting raw expression counts, demonstrating significant enhancements in tissue modeling based on the specimen preparation. Visual assessments on specific genes confirm these findings. We evaluated the models on H&E slides for a few select genes. So I just want to note how sharp and precise the inferred patterns are when the same exact kind of data is used to train the models, clinical grade. Now we can see here that manual staining of the training set led to far fuzzier results. And then if we take a look at what happens when we evaluate the manually stained slide as validation, the quality of the results is significantly degraded, even when training on tissue with the enhanced protocol. And this was also true based on data trained with both protocols. So clearly, there is an impact of specimen processing, and this could potentially be a way to improve machine learning models for spatial transcriptomics. Just revisiting our data valuation assessment, did the algorithmic benefits outweigh the costs? The answer was also exceedingly yes. Not only do we find that the enhanced protocol was more cost-effective on a patient-by-patient basis, but we also found that the assay data was responsible for significant algorithmic improvements on a patient-by-patient basis, whereas the data acquired using the traditional workflow did not. So from the previous few slides, I discussed initial work to improve these workflows by focusing on tissue quality, and by quantifying the importance of tissue processing and imaging through data evaluation, we could potentially identify tissue of sufficient quality for developing clinical grade workflows at scale. So aside from our spatial inference technologies, I just want to briefly preview some of our upcoming work, which integrates data from various spatial profiling assays, which, as many of you have noted today, this is a new frontier in spatial analysis. For instance, we've co-profiled spatial transcriptomics data with nearly every element of the periodic table at near cellular resolution, where the abundance of these elements have previously been implicated in biological pathways relating to tumor growth and spread. What can we do with this kind of data? Well, as a coarse preliminary assessment, for instance, we pinpointed immune activation signatures located linked to copper, the localization of copper within tumors, amongst many other metals that we identified relating to collagen remodeling and other factors creating an environment permissive for metastasis. So while I don't have time to further discuss This is something I'm really excited about. It's new, we're still working on this, but would love to follow up with anyone who's interested in discussing after the presentation. So I'd like to conclude today's presentation by highlighting the exciting opportunities in machine learning-based analysis for spatial technologies. I've shared how my team is in the process of creating an affordable test using AI to deduce spatial molecular information. However, additional research is needed to envision how these technologies can fit into the clinical workflow. And while you can see our preliminary findings are encouraging, they also offered numerous areas for further investigation and growth, including how we prepare specimens and integrate findings with other types of data, along with considering opportunities for further validation and barriers to implementation. So I'm really enthusiastic about potential collaborations in this area that I discussed during today's presentation. If you're interested in further discussions or potential collaborations, feel free to reach out to me using the contact information I provided on the right. There's many folks I'd like to thank from the student trainees who have access to so much information nowadays that I could never have dreamed of, and they're soaking up all this information like a sponge. And I'd also like to thank those who supported me as a professor at Dartmouth and now at Cedars-Sinai, along with multiple sources of funding from the NIH to the Department of Defense. And with that being said, I'm happy to take questions, and I just want to thank you all for your time today. Thanks so much.
Thank you. Any questions for Dr. Okay, go ahead.
Sure. I guess a couple of minor questions. Like in terms of scale for training data, I mean, that's the limitation for a lot of these prognostic and predictive AI for clinical. What's the breadth that we need in order to capture kind of rare cases examples? And then two, how accurate do the predictions need to be applied in the clinic?
Let me start with the first question. So rare cases, I'd imagine that could be challenging, right? I mean, I think for anyone developing a clinical assay for various tissue that representing rare conditions, it's a major challenge. I think certainly consortium efforts exist that pull together tissue across multiple institutions. That's one way we can work on this issue, but certainly it is a challenge, but we do a lot of research in Bayesian methods. I don't want to go straight to methods, but certainly, right, there are certainly algorithmic approaches for how do we handle instances of bias when we don't have enough data, and certainly that's one of many approaches. Your second question was about the minimal accuracy needed. And at the end of the day, right, we're studying all these markers. We're predicting expression across 1,000 genes. Some of them are accurate, some of them aren't. We're not going to use the ones that aren't accurate. We're also going to make sure that we have a clinical endpoint in mind. So right now we're studying metastasis. So we're actually starting multi-center validation work between Dartmouth and Cedars, and what we're trying to do is we're trying to essentially emulate a spatial analysis, identifying recurrence markers. So, right, we're fitting Cox models, we're identifying survival outcomes, et cetera, that'll motivate which markers should ultimately be selected. And at the end of the day, right, part of it comes to trust. Would folks trust a spatial RNA readout? Maybe, maybe not. But could this be a tool that could help suggest maybe various tissue stains that should be ordered? Perhaps. Good question, by the way.
Very thoughtful, William. I'm just wondering, for your enhanced workflow, is it just a matter of, histopathology, that's H&E staining and imaging and that aspect, or does it also apply to the transcriptomic process?
The spatial transcriptomics is done in the exact way as recommended by 10x Genomics. I think certainly what we had to do is we had to modify the protocol slightly because, and I could be out of date here, but most of the protocols only account for manual tissue staining, and that can be problematic for the assay chemistry when you try to switch over to automated staining. So we had many meetings with 10x for how we would change our staining and imaging practices and how we could get it to to fit in the current workflow. The spatial genomics assaying is the same. It's really about what we're doing in the pathology lab. I actually spent a lot of time meeting with the histotechnicians and sitting down with them to stencil out capture areas, etc. So it was a lot of fun.
Thank you.
Mhm.
I mean, you took my question right up. I mean, that's a sarcoma specialist at the end. We deal with very rare cancers. I mean, they're less than 1% of all cancers diagnosed in adults, and less than 10% of all cancers diagnosed in children. And in just sarcomas, there are over 100 different subtypes. And then when you begin, and I actually collaborated with a group in rhabdomyosarcoma looking at Javed at the NCI, does computational bio as sarcoma. And he was making the case that looking at an H&E style, I mean, H&E slide, that you could actually predict the underlying different molecular subtypes. But it was done on such a small group of sets. And so when you keep sort of repeating your algorithms and analysis on the same sample, you just introduce bias constantly. And so how can you be confident about that, right? And so my question to you, I mean, and this is of course coming right on the trails of Gemini, debacle. What needs to be done to actually bring it to the sort of end user at a broad sort of level? I mean, across, because clearly, I mean, the machine's going to be better than any pathologist in counting cells and all that. I mean, that's there. But in sort of recognizing that something is actually true.
Well, and I think at the end of the day, even if it's not deployed clinically, we could at least use it to identify potential as a discovery tool.
Absolutely. I mean,
for additional markers to follow up on, and maybe we don't capture all, we will try our best to capture as many tissue and patient characteristics as possible. Hopefully this allows us to at least adjust for additional confounders and effect modifiers within really large cohorts to a certain extent. But as you mentioned, I mean, I think, right, there's all sorts of different ways that we're subtyping diseases and further subtyping them. I mean, I think look at various CNS tumors, right? How many times have they been broken down into different histological and molecular classifications? So, I think it's going to evolve just as much as the diagnoses themselves. Classification systems are evolving.
Right, thank you. Any